A 35-year-old morbidly obese female presents with global right ankle pain, significant swelling, and an inability to bear weight after a misstep while descending stairs. Imaging reveals fractures of the distal fibula and posterior malleolus. Key anatomical considerations. The posterolateral approach is the most appropriate surgical method to achieve direct anatomic reduction and fixation of both fractures. The approach uses the internervous plane between peroneal tendons, innervated by the superficial peroneal nerve. Flexor hallucis longus, innervated by the tibial nerve. Pathophysiology of the injury. Posterior malleolar fractures occur in the context of rotational ankle injuries, commonly alongside fractures of the lateral and/or medial malleolus. The posterior malleolus is critical for preventing posterior talar translation, which acts as a bony buttress, serving as the origin of the posterior inferior tibiofibular ligament, contributing to syndesmotic stability. Surgical management. Direct anatomic reduction, critical for restoring joint congruency and stability. Posterolateral approach provides optimal exposure for reduction and fixation of both fractures. Advantages of the posterolateral approach. Direct visualization of the posterior malleolus and distal fibula. Allows anatomic reduction and stabilization in one surgical exposure. Anatomical interval used between the peroneal tendons, innervated by superficial peroneal nerve, and the flexor hallucis longus, innervated by tibial nerve. Viva questions and answers. What are the key stabilizing structures of the ankle syndesmosis? The posterior inferior tibiofibular ligament, anterior inferior tibiofibular ligament, interosseous membrane, and interosseous ligament. Why is the posterior malleolus important in ankle stability? It acts as a posterior buttress to the talus and provides an attachment for the posterior inferior tibiofibular ligament, which stabilizes the syndesmosis. What is the internervous plane used in the posterolateral approach? Between the peroneal tendons, superficial peroneal nerve, and the flexor hallucis longus. Why is direct reduction preferred over anterior to posterior screw fixation in large posterior malleolar fractures? Direct reduction allows for better visualization and ensures anatomic alignment of the articular surface, which is critical for joint function. What are the complications of inadequately reduced posterior malleolar fractures? Post-traumatic arthritis, persistent syndesmotic instability, and reduced ankle function. What does the posterolateral approach allow surgeons to address simultaneously? Both the posterior malleolus fracture and the distal fibular fracture can be reduced and fixed through a single incision. Why is the posterolateral approach particularly useful in obese patients? The approach minimizes soft tissue dissection and provides excellent access to the fracture sites with less risk of wound complications. What imaging findings indicate a posterior malleolus fracture? Radiographs may show a posterior fragment on the lateral view. CT imaging is often used to assess fracture size and displacement accurately.